So Mira asked me to tell you the up-to-date treatment with all the novel therapies. And it's a good time because last week we had a meeting, like every year, it was in Brazil, where all the specialists discuss their results and explain what are the new treatments. The first important point is the goal of treatment. The goal of treatment now is to achieve what we call minimal residual disease, which is MRD. And MRD, you don't see any malignant cells on the microscope, 0 cells on the microscope, but you can detect up to 1 malignant cell in 1 million cells by special techniques which are called next generation flow, next generation sequencing, so very sophisticated techniques, but which are able to detect very low number of malignant cells. So the news which we heard last week was that the FDA, the US FDA, accepted these techniques as a new definition for the goal of treatment. And the official level for MRD negativity definition is 1 cell out of 100,000. So this is important because now it's possible to approve a drug, a new drug, based on this result. And it's also, I will explain that later, it's also the objective of current all clinical trials. So I come to the treatment of newly diagnosed multiple myeloma, and I start by younger patients who are able to tolerate hydrotherapy and autologous transplantation, what we call transplant-eligible patients. So the standard treatment until now is on this slide. We start with what we call an induction with 3 drugs, Velcade, thalidomide, dexamethasone, or Velcade, Revlimid, dexamethasone, or this one, carfilzomib, Revlimid, dexamethasone, which is actually not reimbursed in many countries. 3 to 6 cycles. Then the autologous transplantation after hydrotherapy with high-dose melphalan, 1 or 2. I will explain that later. After that, you consolidate the result by 2 to 4 courses of the same triple combination, and you finish with maintenance with lenalidomide for 2 to 3 years or until progression. So this is a complex strategy, but which is currently realized all over the world. So this treatment yields very good results, but we have already improved. And we have improved with the introduction of a new class of agent, which is called anti-CD38, and which is represented by 2 drugs, daratumumab, and another one is atuximab. I heard that you have patients who are treated with daratumumab. So currently, we add either daratumumab or isatuximab to the triplets that I just described. So that means VTD plus daratumumab, VRD plus daratumumab, or VRD plus isatuximab, or carfilzomib KRD plus isatuximab. So different models with the addition of one of these 2 molecules, daratumumab or isatuximab. And this leads to a number of very important clinical trials. These trials are randomized. That means that we compare the standard treatment with the new treatment. And it's by chance. It's random, by chance. That is the only way to see differences between two treatments. So all these 6 trials showed a benefit of the addition of daratumumab or isatuximab, for instance, for what I define as minimal residual disease negativity. The percentage of patients achieving MRD negativity was much better with the quadruple combination compared to the triple. We are now probably able to reach 75% of patients achieving MRD negativity, less than 1 malignant cell out of 100,000. And this translates into a longer survival without progression. All these curves show an improvement in the survival without relapse. So with this new induction with quadruple, with 4 drugs, we now question the role of what we have to do after transplant. And for instance, do we need to perform 2 transplants as we did in the past? In the past, double transplantation has been shown to be beneficial mostly in patients who have not a good result of the induction prior to autologous transplantation, or who had a very high-risk myeloma. So now, with this very effective quadruple combination, maybe we don't need 2 transplants, even in high-risk patients. For instance, in France, we have a trial which compared 2 transplants to 1 transplant after a very effective induction with 4 drugs. I told you that after induction, transplantation, consolidation, we have a long-term maintenance treatment. And the current treatment is lenalidomide. This treatment delays progression, but finally patients relapse. So if we want to improve, there are several possibilities, and one of them is, again, to add daratumumab to lenalidomide. Currently, we are not sure that the addition of daratumumab to lenalidomide is useful for all patients. We have this trial, which is called the Perseus trial, which compared the triple VRD plus lenalidomide maintenance, the standard treatment, to the new one, daratumumab for induction, daratumumab for consolidation, and daratumumab for maintenance. And this trial shows that the survival without progression is very high and much better with daratumumab. But actually, we don't really know whether the addition of daratumumab here is useful because the patient has already received daratumumab before. So we don't know whether it is this or this which prolong the duration of survival without progression. There is an argument which is the increase of the proportion of patients with MRD negativity during maintenance here. With this one, you have more patients coming to MRD negativity than with this one, which is an argument. The only way to show a benefit is to compare after transplantation, supposing that all the patients receive the same treatment before. And this is the design of a trial which was shown at the last meeting in Brazil. So all patients are compared after transplantation lenalidomide versus thalidomide plus lenalidomide. And the combination is better. But I have to say that all patients were treated without daratumumab before. We still don't know whether adding daratumumab is useful in the patient who received daratumumab in the very beginning. So this is the conclusion. Currently, we can say that quadruple combination, quadruplets, are better than triplets. And with maintenance, we will have very long survival without progression. And that is the reason why the objective of the trial is no longer survival without progression, because we will have to wait too long. It is MRD negativity. Okay, for younger patients, so we go for the progress in older patients, which is the most important because the majority of patients are more than 65 years of age and are not eligible for transplantation. And things are moving very rapidly. I would say that 5 years ago, the standard was lenalidomide plus dexamethasone. Very simple treatment, oral treatment, well tolerated, good results. That was the standard. But 5 years ago, a first trial showed again that the addition of daratumumab did improve the survival without progression and the overall survival. So if possible, and if daratumumab is reimbursed, which is not the case in many countries for newly diagnosed patients, the standard of care is now following this MAIA trial, the combination of daratumumab plus Revlimid, lenalidomide, plus dexamethasone, triple combination. Now, older patients can have almost the same prognosis as younger patients. But maybe we can do even better, and you could do even better with this slide. I told you that the standard of care is this one. When you add daratumumab, you have the MAIA trial, Dara Revdex, but there is another standard, which is Velcade, Revlimid, dexamethasone, VRD. And you can also add daratumumab or isatuximab to have a quadruple combination, daratumumab or isatuximab, VRD. And in France, we did the same, starting with this one and adding Velcade to come to this quadruple combination. So if Dara Revdex is reimbursed, Dara VRD could be reimbursed as well. Velcade is generic, it is not very expensive. So these are the trials which compared 4 drugs to 3 drugs. This one compared isatuximab VRD to VRD. This one compared isatuximab VRD to ISA-RD, and this one compared Dara VRD versus VRD. Same design. And the results are in favor of the quadruple. This is the IMROSE trial, survival without progression, with a fantastic 5-year survival of 60% without relapse, free of disease, better with 4 drugs in purple than with 3 drugs in green. And this is related to a higher rate of good response and especially of minimal residual disease negativity. Here is the response rate, better in purple than in green, and here is the MRD negativity, better with the quadruple than with the triple. At the meeting last week, we had the result of the second one. This was in Rio. the second one, the benefit trial, is our own French trial. Again, you have more response and more MRD negativity with the quadruple. So this is a summary which started, I would say, in 1970 when I started my career with MP. We added thalidomide or Velcade. Then we are RD, we added VRD, and then we had daratumumab, DRD, and the best will be the quadruple, VRD plus daratumumab or isatuximab. And I just show this one, which is the last trial, the third trial, Cepheus, which was presented for the first time in Rio, and exactly the same result, better result with the quadruple than with the triple. So to conclude, we can say that now the best treatment for older patients over the age of 65 is a quadruple combination of VRD, Velcade, Revlimid, dexamethasone, plus daratumumab or isatuximab. I say isatuximab because it is a French drug.
Yes, okay. Is it
which
cheaper?
Will be cheaper.
Oh, will it? That's okay. We'll have it.
Okay, so the last part of my talk is relapsed multiple myeloma. We hope to cure multiple myeloma. No relapse, but currently we still have relapse. Multiple myeloma is a chronic disease with relapses, retreatment, relapse again, retreatment, and we now have many possibilities of treating relapses. We have many new drugs, but the most promising ones are what we call immunotherapy, which has been used in other cancers, skin cancer, lung cancer, leukemia, but which is also very active in multiple myeloma. Actually, daratumumab and isatuximab are immunotherapy. They are what we call antibodies, which recognize a target on the myeloma cell and kill the myeloma cell. But there are more complex immunotherapy which are on this cartoon. So here is the myeloma cells. The first procedure is what we call CAR T cells. A CAR T cells is an immune cell from the patient, a lymphocyte, which has been modified, genetically modified, to recognize the target on the plasma cells. So the cell here comes to the target, which is called BCMA, and kills the myeloma cell. CAR T cell, engineered lymphocyte T for killing the cell. Another possibility is what we call antibody-drug conjugate. This is an antibody like daratumumab, not the same, which recognizes again the BCMA and which is linked to a toxic drug. So the antibody comes into the cells, attacks, links to the cell, and the drug comes into the cell and kills the cells. And the third one is what we call bispecific antibody or bispecific T-cell engagers. So this is the antibody here, which links to the lymphocyte, to the T-cell, and at the same time links to the myeloma cells. So it attracts the lymphocyte to the cell, and it kills again the myeloma cells. So 3 fantastic improvement, technical improvement to target specifically and kill the myeloma cells. What is very encouraging for myeloma patients is that we have multiple targets. We have CD38, daratumumab and lenalidomide. We have BCMA for all these drugs, but we also have this one, GPR65D, FCHR7, and all this one could be targets. So for the future, it gives many possibilities. These are the drugs which are currently available or in development. So, for instance, the CAR T cell, the first one, we have two which have been registered in the United States and in Europe, the ID cell and the cilta cell. For the antibody coupled with the drug, we have one, which is here, belantamab mafodotin, which we call belamaf. And for the bispecifics, there are plenty of them, many of them, but currently two have been registered, teclistamab, elranatamab. The other are in development. And as I told you, we have other targets. For instance, we have this one, and there is already talquetamab, which has been registered by the FDA and by the European Agency. And you have this one with not yet registered, so plenty of possibilities. Obviously, all these drugs are very expensive, and it's difficult to obtain the reimbursement in many countries. So in many countries, the best way to have the drug is to be included into a clinical trial. So very rapidly, I give you some ideas of the result we can achieve. First, belamaf. We thought that this drug would disappear because 5 years ago, the results were not very good, 30% response, and a very special toxicity, ocular toxicity. So the future was not good. But at the last meeting, international meeting, last week, we had the result of 2 studies with belamaf in combination with other drugs. And the results are very excellent. The DREAM7 with belamaf plus Velcade plus Dex, which here in orange, which is better than daratumumab Veldex, which is a classical relapse treatment. And here's a DREAM8, belamaf pomalidomide, another drug active in relapse. Yeah. Same family as lenalidomide. Dara-Pomdex versus pomalidomide Veldex, and again, the new combination is better. So it could be a revival of this drug because these results are really excellent. And of course, we still have the problem of ocular toxicity, but we now know how to manage. We delay the injection of the antibody to reduce the ocular toxicity. The drug is approved in Europe, but currently is not reimbursed because the results were not good. But the pharmaceutical company will apply for, again, trying to obtain reimbursement in combination. This busy slide is just to show you the initial result of the 5 other licensed drugs. ID cell, a CAR T cell, which is study KARMA-1, cilta cell, a CAR T cell with this study, teclistamab, a bispecific antibody, elranatamab, a bispecific antibody, and talquetamab, a bispecific antibody directed to another target. So these are the 5 licensed new drugs, new immunotherapy. What I want to show you is that these drugs were tested in very advanced multiple myeloma patients who have already received a large number of combinations for relapse. For instance, here, the median number was 6,655, but some patients had received up to 20 lines of treatment. So very, very end-stage multiple myeloma with no other possibility, the end of the disease. And you see that they were refractory in the great majority to all drugs, to the Velcade class, to the lenalidomide class, and to the daratumumab class. So no therapeutic possibility. The first CAR T cell gave 1/3 of response, which has 1/3 is not much, but remember that there were no possibility. So it was licensed based on this result, 33%. The second one was really a revolution. A revolution. Cilta-cel gave almost 100% response, including 2/3 of complete response, end-stage patient. And this translated into median survival without progression of 3 years. 3 years more in patients who had no possibilities. What is interesting is that only one infusion, only one treatment after this is finished. Of course, this injection is very expensive. In France, is 350,000 euro. This treatment induced new toxicities.
They didn't like the price. They didn't like the price.
This is?
They did not like the price for one injection.
I understand that, but some economists did the analysis of what they call cost effectiveness, cost versus efficacy. And these drugs is cost effective because it is in place of very expensive, less expensive, but very expensive, with daratumumab, for instance, that you give for months. But more importantly, the survival is much longer with this treatment. So, of course, it's very expensive, and in many countries, we don't have access currently. Even in France, this is a very restricted access to this drug. I finish by showing this. These are the special toxicities. One is called CRS. That means cytokine release syndrome, which is a sometimes very severe syndrome with fever and low blood pressure. And this one is neurotoxicity, which was unexpected. So these are limitations of this treatment. Rapidly, the 3 antibodies here, they have approximately the same efficacy. Roughly 2/3 of patients, again, end-stage patients, achieve remission, including 1/3 of complete responses. They have much less special toxicity, much less CRS, or much less neurotoxicity, but they induce infections and even long-term infections. So it is necessary to take prophylactic measures like antibacterial or antiviral prophylactic treatment or prophylactic IV or sub-Q immunoglobulins. In my country and in many countries, the drugs are not reimbursed if there is no evidence of the superiority of the new drugs compared to the standard treatment by a randomized trial. So that is the reason why the company performed these randomized trials for ide-cel, for instance. This is a randomized trial comparing ide-cel versus the best treatment for relapse. And you see that ide-cel is much better, especially with a much higher response and complete response rate. Note that this was in a less advanced patient, 2 to 4 lines of previous treatment. That means that in the future, when we can have this drug reimbursed, in the future, it could be used much earlier. And this is the same with the other one, probably the best one, Cilta-cel. You see here, in less advanced patient, 1 to 3 prior lines of treatment, a very good result, fantastic result, compared to the standard combination we use for relapsed multiple myeloma. And I finish with this complicated slide. It's just to show you that there are plenty of clinical trials which are currently ongoing in different indications. Of course, it's for the future because these studies are just starting. But look, they are already testing CAR T cell, for instance, cilta cell, in newly diagnosed multiple myeloma. I'd show you the standard of care with quadruple therapy and autologous transplantation. They try to replace autologous transplantation by cilta cell. And here, in elderly patients, they try to add cilta cell, one injection of cilta cell, to the quadruple therapy in order to further improve. So this is the future, of course. And it is the same with the bispecific antibody. For instance, this one is in maintenance. They try to use bispecific antibody in addition to lenalidomide or instead of lenalidomide for maintenance after transplant with teclistamab or with elranatamab. Well, this is the current situation. I think that you have understood that the most important is that we are now able to reach very high level of tumor reduction, which are correlated with long survival without progression. But what is also important is that when the patient relapses, we have now many, many possibilities. So it's always possible to achieve new long remission and to increase the overall survival of multiple myeloma. Of course, for us in Europe, not only for you, but even for us in France, one of the problems is access to these new drugs because of their cost. And it's sometimes a long way before convincing the authority and the pharmaceutical companies to make an arrangement in order to give access to the patient for this very attractive drug. I'm very happy that you have now daratumumab. I'm pretty sure that in the near future you will have probably one or two bispecifics for relapse treatments. Maybe not this year, but in the near future. Okay, with that, I thank you very, very much for your attention.